It is now my pleasure to introduce Dr. Claudio Manubens, Chief of Cardiology, Advent Health of Florida in Davenport, Florida. He is going to share his expertise on Guardian patient selection. Dr. Manubens, the stage is yours.
Thank you, Dr. Kaplan. I hope everybody can hear me, and hello, everyone. I'm just going to take more of a personal approach of my own experience after I've embraced this technology. As Chief of Cardiology, we review STEMIs every month, and average of 10 to 15. And something that has really boggled my mind is the number of young patients actually that are coming into the emergency room with acute coronary syndrome. You know, back in the day, it used to be in the 70s, 80s. Now I'm seeing patients in their 50s and 60s, young patients coming with acute coronary syndrome. And obviously, sometimes the outcome is not good, especially when you're do a little bit of research and find that some of these patients are not showing up from 12 to 16 hours after the initial event. And as someone already mentioned, time certainly is muscle. And, you know, we do a very good job in the emergency department to make sure that we get that EKG within 10 minutes and, you know, door to balloon within 90 minutes. But it doesn't do us any good if we are not getting these patients to come into the emergency room. So I embrace this technology because I know that we're in a time where, you know, we have AI, we have also, you know, great technology. I know my car is always reminding me to pull over and have a cup of coffee when I'm driving erratically because I'm answering calls or texting or whatever. So why not offer this technology to our own patients? And I've embraced this for the last probably 9 months or so. And I found that most patients actually that are in this situation, we know that AFib begets AFib and stroke begets stroke. Certainly acute coronary syndrome is something that we can't just ignore it, you know. And I used to tell my patients, you can't predict myocardial infarction, you can't predict an earthquake, but now we know that that's no longer the case. So if we have this technology, why not use it? So we know that some of our patients present with some atypical symptoms. You know, we had a patient last week where actually presented with epigastric abdominal pain, was getting a KUB, CT of the abdomen and pelvis, and the emergency room doctor said, well, I did an EKG just because the patient was 70 years of age. And lo and behold, you know, ST elevations, inferior leads, patient went to the cath lab immediately, had 100% right coronary artery. So we have to look for patients that may be diabetic, smoker, multivessel disease. We know females present with typical symptoms, underrepresented minorities, atypical chest pain, as you can see in the list. So we always want to be alerted and kind of be proactive, ideally. That's what I tell my patients, rather than be reactive at 2 in the morning, I'll call 911. I'd like to just present a couple of studies. You know, some of my patients, the one on the right, for instance, a 62-year-old female, an avid golfer who, you know, had some silent event, no symptoms, but after having distal left main and 99% occlusion of the osteo-LAD, went for Lima to the LAD, her activity was very much curtailed. She's had a typical depression post-MI. And, you know, I talked to her frankly and candidly about this technology, and she embraced it right away. And after that, I think, as it was shown in the patient testimony, my patient now feels much better. She's able to play golf. She's active. She's not worried about the next event, you know, so she can live at peace. And I think that's a wonderful, wonderful way that we can improve the quality of life. We're all about quantity of life, but here in this case, I think we're doing both. And the second patient I want to talk about is a young male that I had done a cath and actually only had about 30% stenosis, a minimal plaque. I said, everything is fine, don't worry about it. And a week later, his wife calls me and says, well, he's having chest pain. I think he needs to go to the emergency room. And he said, no. Doctor just said everything was fine. Well, lo and behold, I told him to go to the emergency room. Sure enough, he was having acute coronary syndrome, but in his mind, there was really no reason for him to go to the emergency room. So I think spousal stress relief with Guardian is obviously very, very important. And the third case I'm going to present, I'm sorry, it's not in the slide, actually happens to be my brother-in-law, and I like my brother-in-law. And, you know, 52 years old, diabetic, no symptoms whatsoever. Finally, I convinced him to get his cath done. Certainly had 100% right coronary artery with left right collateral, so something that happened probably a while ago. His LAD was 90% proximal, circ was 80%. decreased left ventricular systolic function. I'm talking to him about bypass surgery. He's like, well, let me check my schedule, maybe 2 weeks from now. I said, no, we're going right now. We're going right now for CABG. And he also became another candidate for this device. And now he feels much more at ease, and certainly my wife is much happier than for this case. So for me, any patient, as Dr. Kaplan described, any patient with acute coronary syndrome who's had higher risk, anybody who fits that criteria, what I do is I just talk to them. I said, listen, we do have this device. I want you to learn a little bit more about it. And I'm going to schedule you to come back next week. And one of our reps, Matt is in my case, will come to the office. We'll show you a slide. We'll show you a film. And then you can discuss it. You can discuss it with him, look at the pros, and look at the benefit, look at the risks, and then make a decision. And right now, I would say about 80% of the patients that I discussed, they've been very much willing to go through the procedure. I asked one of my EP guys to do it. I could do it myself, obviously, but I'd rather just let somebody else do it, and who has great expertise. But certainly any cardiologist who feels comfortable doing pacemakers shouldn't have any problem doing it. And not only it's a great sign of making sure that everything is fine with acute coronary syndrome warning, but also, as was already stated, I've been finding myself doing a lot of medication titration to improve quality of life, whether it be tachybrady syndrome. And, we all know that a 24-hour Holter monitor is kind of worthless, right? We say everything is fine. We don't really know what we're looking at. So I think this gives us great relief in improving patients' quality and quantity of life as well. So I'll stop right here, and I'll be glad to answer any questions from my personal experience. Thank you so much.
Thank you, Dr. Manubens, for your enlightening insights. Great cases.